ECDC On Air,
the podcast of the European Centre for Disease Prevention and Control.
Keeping up to date with European epidemiology.
Hello, welcome, and thanks for tuning in to ECDC On Air, the podcast of the European Centre for Disease Prevention and Control. I'm your host Lee, recording from our headquarters in Stockholm, Sweden. On today's episode for World Tuberculosis Day 2026, we're going to be talking about the realities of TB. Tuberculosis is often mistakenly viewed as a romanticized disease of the past, something that affected 19th century writers and artists. But actually, TB is very much a modern reality. While it is becoming rare in many countries, it still exists in Europe, affecting roughly 40,000 people every year in the EU. It is a curable disease, but it is not a typical bacterial infection that can be resolved with a short course of antibiotics. Treatment requires a significant time commitment, and the disease disproportionately impacts vulnerable populations, such as refugees, asylum seekers, and those living in poor conditions. Today, we are tracing the journey of TB with Senia Rosales-Klintz, expert in tuberculosis here at ECDC. We're going to talk about how it can hide in the body, the sometimes difficult reality of modern treatment, and the systemic gaps that cause people to fall through the cracks when it comes to treatment and follow-ups. Senia, thanks for joining us today. Before we begin, could you tell us a little bit about your work here at ECDC?
I work as a tuberculosis expert at ECDC since 2016. So basically, my activities is to coordinate with our counterparts in the European countries on all that has to do with tuberculosis prevention and care.
So today is World TB Day, and we're going to be talking about the reality of TB in Europe. So to start us off with, many people think of TB as sort of consumption, this sort of romanticized disease confined to the history books. Can you outline the current situation and explain how TB still poses a significant threat and challenge to Europe today?
So I think the first thing to point out is that tuberculosis still exists in Europe. That's something that is important to remember. And every year, roughly 40,000 people in Europe are diagnosed and treated because of this disease. In comparison to the global situation, our part of the world is having less of a problem. We have less TB and we are perhaps closer to eliminating it, but there is still plenty to do. There are many people who are affected, and mainly those who are already in deprived situation and or are more susceptible not only to disease but also other social conditions. So it is an important public health issue that we have to take care of.
So you said that there's roughly 40,000 people that present with TB. In a continent of 500 million people, that sounds quite a small number. And so as it's becoming increasingly rare, at least in the EU, is there a risk that health professionals might initially overlook the symptoms when someone first presents with a persistent cough or a lot of fatigue, things like that?
Let's start with the symptoms that you mentioned. I think it's important that everybody is aware of what could indicate suspicion of tuberculosis. And as you correctly mentioned, it's starting with a very prolonged cough that doesn't go away after 3 weeks. But it's also accompanied by night sweats, you lose weight without any other reasons or not really looking after that. So that is the first point, because we have qualified healthcare providers that will be able to pick up once you present to the services. But then the person, him or herself, need to go to the health facility. So that's where it's a two-way. I'm confident that we have the capacity in Europe and the know-how, and that healthcare providers know about it. Yet it's also important to mention that because it's becoming more rare, and also because people as professionals perhaps have not been exposed to treating patients in the same extent that other diseases, may not be as familiar. But I'm not concerned of us losing or not detecting on time, because there is a very well-established way of working. There is the tools to diagnosing on time, and we also have the ways of treating properly. But of course, we have always to keep in mind that tuberculosis could affect anyone, anywhere.
If the average person in Europe is unlikely to encounter or catch TB in their day-to-day life, who is primarily affected by the disease?
We have different profiles of people that are more likely to get sick with tuberculosis. We have those who are more exposed to the pathogen, which is a bacteria, basically. And those could be people who have been traveling abroad or born abroad in places where the disease is much more common than what it is in Europe. We also have people who are elderly and perhaps they were exposed to the bacteria when they were much younger. And with age and, as our immune system goes a bit more weaker, then they start presenting symptoms really late in life. And we also have those people who have other medical conditions that affect their immune system, either directly or indirectly through the medications they need to take. And they are also more prone to developing disease. But as you say, it's not a disease that affects everybody in the same stretch. You need to have a series of factors, a combination of characteristics. Your immune system has to be sort of weakened. You have to be exposed constantly for long periods to the source of the infection. And basically, you should not be able to cope on your own trying to contain the disease.
I'd like to move on a little bit to the biology of the infection itself, and how it actually works. So, what exactly happens when the bacteria enter the body, and what's the difference between having the bacteria sleeping inside you for a number of years and then developing active symptoms?
I think in my brain, it looks a bit like a hide and seek type of game between our immune system and the bacteria. So basically, the usual way the bacteria enter the body is through air. So we inhale it. It's the bacteria floating, we inhale it, it goes to our lungs. That's the touching point. When it's in our body, the immune system will try to contain. It's like the police of our body will immediately try to identify who is the intruder, will try to contain it and kill it. That's the mission. So once the immune system enters into action, there are three possibilities. Number one, that they succeeded. They localize everything that came in, kill all the bacteria. There is no problem. Probably we will never know that we were in contact with the bacteria. Then they can succeed to identify and contain it, but probably not killing everything that came in. And that's where this sort of sleeping, dormant, hidden group of bacteria may happen. And this is the hiding part of the game. So the bacteria will be trying to sort of escape from the threat that poses the immune system, and they will hide somewhere in our body as long as needed. And that period can be months or many, 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 many years. And they will just come up once the conditions for them to grow and to continue sort of propagating themselves is proper. And we will never know. And then the third option is when the bacteria wins the game and they can overcome the immune system. And then they will almost immediately, after that first introduction in our body, start causing major symptoms and causing disease. And obviously, then is when we have the symptoms we have been discussing earlier.
You've sort of touched upon it a little bit there. My next question is just this idea of the bacteria sleeping in the body. I mean, is one thing we've seen in the data is that a lot of elderly people do develop TB decades after they could have possibly caught it. Is this one of the most vulnerable risk groups that we're sort of seeing elderly people with weakened immune systems, and they should be extra careful that they might have caught TB earlier in their life?
I think I will not say that they need to be extra careful, but perhaps mindful that can happen to them. I think roughly speaking, about 20% of all the yearly cases we see in Europe are among people above 65 years of age. And the older you are, most likely is the case that you were exposed at a very early age in a different period of time that we're living now, where the living conditions were not as good. And then life progresses and we forget about that. And it could sort of basically the bacteria can just wake up and it might not be such an obvious connection. So we have to be mindful that it happened. We have to understand that elderly people may have an exposure that we are not aware of. But in terms of which are key vulnerable populations, I think we have other groups that would require more attention also as a means of trying to prevent further transmission of the disease than the elderly.
I want to move on a little bit to the patient journey and the sort of reality of getting treatment. So what happens when someone develops symptoms? They go to the doctor. We know that European healthcare systems are generally quite good, but once the disease is diagnosed, what does the treatment journey look like, and how is it different from taking antibiotics from other diseases that we might have?
Yeah, so if we compare with a sort of so-called normal bacterial infection, that could be a respiratory infection or a urinary tract infection, we get what we at that point will consider a long treatment of about 5, 7, 10 days with one antibiotics. For tuberculosis, we're talking about 4 to 6 months of treatment with antibiotics, which is a combination of at least 4 medicines. And that gives you perspective. It's really long in comparison to other bacterial diseases. It requires a combination of medicines to avoid that the bacteria gain resistance to the medicine, that they can avoid them. It has to be constant. And during that period, it's important to provide as much support to the person who is being treated because it's not easy. It's not easy to remember to take the medicines. Sometimes you can also experience some effects related to both the disease, but perhaps associated with the treatment you are getting. So there are many factors that play a role when you are under treatment for so long time. And especially because during treatment, you will start feeling better. So as any person, you start also questioning, what should I continue with my medicines if I feel better? But internally, the bacteria are not quite killed completely. And that's why we have to be persistent and consistent and make sure that everybody who has a diagnosis of tuberculosis complete the whole treatment regimen. And also to make sure that each individual receives the best treatment regimen for the type of disease they are having, because there are also differences and has to be adapted and follow up properly.
During the initial weeks of treatment, what are some of the more practical steps and basic rules people should follow, maybe to protect the people living in the same housing and things like that when a person is still infectious?
It's important that we talk about this because, first of all, once you have been diagnosed and started on treatment, and it is a normal course of disease without resistance to the medications, within 2 weeks after you start your treatment, you will not longer be infectious. So even though the treatment is longer, after 2 weeks, you are safe to interact with your family and friends and so on. But during those 2 first weeks, and depending on the conditions in which you have been diagnosed, it's important to have certain precautions. The basic one is to use, for example, a respiratory protection for the person who is sick as a way to avoid the transmission onwards. Also, certain basic isolation measures if you are at home, trying to sleep in a separate room than the rest of the family, ensure good ventilation, which are same measures that would be applied to a work environment. But within the first 2 weeks, it's likely that a person with tuberculosis will remain home or will be taken care in a healthcare setting. And after the treatment has kicked in to ensure that it's not longer infection, the person can go back to the normal routine as much as possible. And especially thinking on young people who might still be in schooling age, it is important to regain these type of routines, but it's also important to ensure that there is no risk for others to get the disease. And as I said also, that it's through the air, so it's no risk for people to hug each other, to share sort of cutlery or spaces, or it's also important to understand how it goes onwards.
Okay, so you've kind of touched a little bit on the next thing I wanted to talk about, really, was the social determinants of health and particularly stigma in this case. So one of the things that we mentioned earlier is a little bit how TB can exploit sort of structural vulnerabilities, um, such as overcrowded housing or poor living conditions. And we're talking about someone isolating for 2 weeks. Um, does this directly fuel the spread of infection?
There are two or three elements to highlight here. We have to acknowledge that tuberculosis historically is a stigmatized condition. So there is a lot of in the subconscious of a culture, of a population, of a person that is rightly or wrongly associated with tuberculosis, and that's the stigma. So it's a negative attitude to what the disease represents and what the person who is suffering it may or may not provide. And it comes with discrimination towards the person who has tuberculosis, but sometimes also to the family of the person who has tuberculosis, to the healthcare professionals who care of the people who has tuberculosis, to the clinic that treats the people with tuberculosis. So it's quite a spread. And also the person themselves may have a self-stigma based on these cultural sort of constructions. So that is one element. The isolation as a protective measure is a biomedical, well-grounded way of trying to protect others and also to restrain the transmission, and is necessary. But it should be done just when really, really needed. So not prolonging it more than necessary, because that also will add on into the stigma and potentially will also create some sort of anxiety and other mental issues to the person who is already sick, because you get very self-aware that people are looking at me or people don't want to relate with me. But it's a bit of finding the balance of providing good care and acknowledging the social elements of this disease that has been around. In terms of the social determinants, we also need to create a better understanding on how the disease is transmitted. Another key difference of tuberculosis compared to other viral or bacterial infections is that it requires a long exposure. So, for example, you and I, we are meeting here for a few minutes. That will not be sufficient if one of us would have had tuberculosis. You need to share a close environment. That means with poor ventilation and no natural light for a long period of time, which is roughly speaking 8 hours over a period of time. So people who are more likely to get infected are relatives, those who live with the person, who sleep in the same room, or those who work very closely. So either in school or in workplaces, if they share space for more than 8 hours regularly over 3 months, that's when it happens. So if we take that knowledge and superpose social conditions, if you are living in a very crowded space because you cannot afford anywhere and you cannot afford to eat properly, your immune system will also be weakened. So you will be more susceptible to catch the bacteria, and the conditions where you're living is also sort of helping the bacteria to get into you. And if you are in a place where you don't know how to seek for healthcare, either because you don't know the environment or because you might be suspicious that it could be tuberculosis, but you are too afraid to go because of a stigma, that's when all these pieces come together and actually create the conditions to disease to flourish.
So based on what you're saying, we can see that social stigma can have a big impact on a person suffering from TB. But how can the diagnosis itself affect someone's willingness to seek help or maintain daily treatment, as it is a daily and long treatment?
I see various ways it can affect. I mean, it's good if you get a diagnosis and then you start a treatment, but because it's such a long treatment, the way how health services have been built on to support people with tuberculosis require that the person has to show up daily to a health facility to take the medicines, to make sure that you are complying or you are following your medication. So some people might feel shame to show up to a specific clinic because that clinic is known to treat people with tuberculosis and then might retrieve. That is related to stigma. So there are various ways in which we can support them, trying to facilitate the treatment either through community support, family support, peer support of other people who have gone through the same, who can relate to the whole journey, but also through technologies. For example, you don't need anymore to go in person. You can make a video call, have the interaction with your health provider in a safe space where you don't need to disclose that you have tuberculosis, yet your treatment is followed and you can still have in contact with this particular person. Or if you have to travel, you don't need to sort of be in one place. You can have devices that help health providers to monitor that you are following up your treatment while you are elsewhere. So now we have these type of alternatives that were not necessarily in place 20 years back as means to both support the treatment and to minimize the stigma. But it's much to do also with education, both of the person who is having the disease and the environment where the person works and lives so that they really feel supported to the extent needed.
We've talked a little bit about how the treatment is quite long, it's quite difficult. There's a lot of stigma around it, around TB in general. What happens when someone, perhaps due to these very difficult circumstances, can't maintain the treatment? It interferes with their work, their family life, and for whatever reason they think, as you mentioned earlier, that I'm feeling better, maybe I don't need to carry on the treatment. What then happens?
Yeah, that will mean that a person interrupted treatment for more than a month. That is the threshold, right? And likely what will happen is that the bacteria that cause the disease will have the opportunity to grow again and not only to continue causing disease to the person, but also will infect others. And because they have already been exposed to the medications, they might not respond to the medicines in the same way. So ideally, to the person who has discontinued treatment, we will try to bring the person back, but then we will have to assess whether the treatment offered in first place is still suitable or if there is a need of changing the medication. And then is when it gets a bit more complicated. Because first we have to rule out that antibiotic resistance has not established itself. And if it has, we need to change the treatment options for the specific person. And with this change, the treatment might be longer. And hopefully, if everything goes as expected, the person will cure. But then we have complicated scenarios in which the disease gets more severe because the medications are not really functioning as they should. And the treatment options are getting less and less. And the person will get sicker. And it will be a more complicated sort of disease to treat, basically, and hopefully cure.
Okay, so this moves us on to drug resistance and other systemic challenges, really. So if someone doesn't complete their treatment, or maybe they've stopped in the middle and they've had to restart, the bacteria then, I guess, can sort of learn to survive in these and adapt to these changing conditions. Can you explain a little bit about what drug-resistant TB means for someone in terms of both the severity of the disease, but also the alternate treatments that they have to pursue?
Well, it means that you will need to take more medicines because probably you will have to expand and change the antibiotics, but from 4 to 6, for example, different combinations, longer periods of treatment. Even nowadays, we have good options in comparison to what was available 30 years ago. So even for people who has this more severe resistance type of tuberculosis, the treatment could still be provided within 6 months, which is a major achievement. But if that doesn't work and the changes continue, the treatment can be prolonged up to 1.5 to 2 years of constant sort of exposure to antibiotics. That doesn't come for free. I mean, you will have potentially symptoms associated with the treatment in terms of dermatological reactions like rashes, or your blood values will change, or you will have toxicity associated with the medication you've been taking for so long. So you will not be feeling well, not only because you're sick, but also with things associated with the treatment you are given. There are cases that are very difficult to treat, and sometimes you have to use very sort of radical options, like taking away part of your lung, is surgically removing the place where the bacteria might have been sort of concentrated in combination with medications as means to trying to really get rid of it. And sometimes that is not enough. And something that is talked very little about when referring to tuberculosis is there are cases, perhaps few, hopefully few, but there are cases in which the medical options are not longer there. So then it's shifting towards palliative care and end of life care. It's basically telling a person, we have done everything we could and giving you everything we could, and now we are just trying to focus into giving to you best quality of life for whatever is of remaining of your life. And we also have to understand that people are dying of tuberculosis in Europe in 2026, which to me is one of the more incomprehensive things. We should be able to help them survive, not only providing them good death.
With that in mind, we know and there are alternative shorter treatments available for drug-resistant TB, but TB in general. But access in Europe, in the EU, can be an issue. Without getting bogged down in sort of complex regulatory detail, what are the main challenges in bringing these types of drugs to Europe, these new drugs to Europe?
Yeah. Well, let's start with the positive notes. Now we have newer, better alternatives. That's great. What we experience in this side of Europe, in the western part, is that we are sort of victim of our own success, which means that because tuberculosis is becoming so rare in comparison to other places, the market is not attractive for manufacturers to sell to us. So sometimes it's that the drugs that are part of these newer treatments are not registered, and therefore we cannot acquire them as easily. Or we have to pay much more. And this is an issue of equity. Of course, most of the Western European countries are high-income countries and could pay more for it. But even for our standards, it makes it a little bit complicated for public health services to provide. So it's a bit of that paradox that we are not necessarily in Europe providing the latest options. And what it means in practice is that at national governmental level, we need to be more proactively looking for options to procure these medicines. People who need them may still access them, but they will need to wait perhaps a bit longer than should be needed. So there is a lot of work to do to ensure that everyone with tuberculosis, regardless if it is a normal tuberculosis or a more severe form, get the appropriate treatment on time everywhere.
Okay, so we've covered a lot of different areas, not only what it's like for the individual, the social determinants of health, other systemic issues. The final thing I wanted to ask about was our surveillance systems. Now, while they're excellent at recording initial diagnoses, there seems to be a significant blind spot when it comes to what happens to people afterwards. Maybe that they start treatment and they leave treatment, or we're not sure. Perhaps they've moved country, and so they fall out of one healthcare system and into another healthcare system. Why is it so critical that we sort of close this gap and sort of track the long-term outcomes of anyone that is suffering from TB?
the obvious thing to me is that we're talking about people's lives. So it's about knowing what happened with this particular individual to have a closure. But in the sort of population level and the public health perspective, there is an agreement among all European countries and other countries in the world that we are going to eliminate the disease. And this type of information help us to monitor how well are we doing towards that common goal. So basically, not knowing what happened with a person after 6 months of treatment is hindering us to assess our performance towards that common goal. There are reasons that relates to resources because it requires extra work to trace and document. There might be reasons related to the person who is actually discontinuing treatment and we cannot find the person later on. But it's important to know because that information will allow us to act and to correct what is needed to be done differently or better so that we can actually eliminate tuberculosis in Europe.
Well, there's a lot to think about there. Thank you very much for all your time today. I hope we can see some better numbers next year in 2027. Thank you.
Thank you.
We hope you enjoyed this episode on TB. If you would like to know more about World Tuberculosis Day or about ECDC in general, please see the notes of this episode. You can find all the episodes of the podcast online. If you like this episode, please share it or leave a review, and don't forget to subscribe on the podcast platform of your choice.